that we have. Does everybody have the slides now for this over here? I am going to talk to Dr. Fashoni and see why some of you can get them and some of you can't get them. I don't know if it's also a computer thing. So we'll try to figure out what the access issue is. But everybody has now access to all of them for this block. Yes? Okay. All right. So looking at this, we're going to talk about fertility and reproductive medication. Did they tell you? Okay. Are you gonna? Oh, oh, okay. Um, we're going to go over these medications. There is going to be a Dickey table that you're given to use on the exam. Don't write on them. I mean, you can while you're taking your notes. I will make all new copies anyway for the exam. This is going to be the way that you can figure out what type of contraceptive you should be giving to someone if they should need it. So I don't want you to be the provider who's like, oh, you need to go to OB to get your contraceptive, because you can do it too, okay? Everybody. Your ELOs listed here for this. I will say on the exam, a lot of it is going to be you looking at the Dickey table, picking out the correct contraceptive for a patient, understanding what the contraindications are for your contraceptives is going to be a big part of it. Looking at the difference between combined oral contraceptives, POPs, which is progestin-only contraceptives, your LARCs, which are your long-acting medications that we have, it's like an implant, IUD type of thing. So all of this is going to be centered around that counseling points, making sure that we're telling patients to still use protection because it doesn't prohibit them from getting an STD, it just prohibits them from getting a baby. And sometimes not even 100% with that, right? So we need to make sure that we are communicating this as providers, make sure that we stress adherence, because when people do miss some of those contraceptive pills, they're not getting the hormones that they need. They can then have an unwanted or an unplanned pregnancy, and that becomes hard, especially for readiness in the military, right? It's a big deal because we need to make sure that people, if they want to plan or if they do or do not want children, that we provide them that care. Looking at all of the medications that are discussed in this lecture, you can see them here. So you have your combined oral contraceptives, your vaginal ring, which is mainly estrogen based, your transdermal contraceptive that we have, which is going to be our patch. We used to use it a lot. We don't use it that much anymore. Your progestin-only pills, we only use these in certain situations because they're very finicky, okay? Like you have to take them around the same time every day. You don't, you could start bleeding at that point. You could become pregnant at that point. So these are the ones that we use them if we need to use them. Your LARC, or your long-acting reversible contraceptives, those are the ones that I was telling you guys about. That will be your implants, your IUDs, things like that. So you see all of those listed there. Injectable contraceptives. So we do have where you can give a depot shot to your patients. We'll talk about that, and it's called Depo-Provera. Your emergency contraceptives. So if all else fails, we all hear and heard about Plan B. But you can also use these in situations, not necessarily saying that someone's contraceptive failed. There are several different reasons why someone could end up in a situation to where they need emergency contraceptive. Just make sure that you are being a provider and not trying to predict or figure out why they need it. Just provide the care. We do have this in the pharmacy. We have Plan Bs. We also have what's called Ella, and we'll get into that. And that one is prescription only. They can't just go over the counter. And then some of our other agents that we have, we'll talk about in other lectures as well, but like our reproductive medicine, so things when there is infertility and someone wants to become pregnant, we have a couple of medications that we can use to induce ovulation. So looking at your physiology, I just wanted to get some terms out of the way because these are the most questions that I get asked on the exam because we don't understand what we're saying when we're saying ovulation, when we're saying menstruation, when we're talking about the endometrium. You're going to get a lot more of this in your senior semester. You're going to see almost the exact presentation again. So I would not learn and dump this one. I would learn and keep it, okay? Your ovulation, so that is essentially saying the egg has been released from the ovary, and at any point, depending on whenever the people have sex, okay? The egg can be fertilized by the sperm. It has to implant for a pregnancy to happen. So So when we talk about contraceptives, they're trying to control when this happens and prevent the pregnancy. They do not terminate pregnancy. So if someone is already pregnant, they will remain pregnant if they're taking this contraceptives on top of it. Your menstruation or your menses, your period, your cycle, these are several different words that people say, thank you, that all mean the same exact thing, okay? This is essentially whenever they are bleeding, okay? This is happening because there was no egg that implanted, right? There's no pregnancy. So then the body cleanses itself and they have their cycle, their period, menstruation, menses. And then your endometrium is the lining of your uterus. And so just understanding when you hear these things, the big point and the big part that catches people is when you see menstruation, understanding period, cycle, all of those things are the same thing, okay? All right, our contraceptives. So we have several different ways that we can give a contraceptive, several different routes. So you have your barrier methods, old school, basic things, right, that we have access to, condoms, diaphragms, sponges, things like that. We're going to go into those. Also, you can let your patients know that we have condoms in the pharmacy. They have them in several different clinics as well. Just make sure they're not expired, okay? Your intrauterine methods, so our copper or hormonal IUD. Copper we don't use as much. We talked about it a little bit when we were looking at some of our psych meds because we said that a lot of our hormones, the efficacy of them would be decreased if we had some of our psych meds and other medications on board. So if we were trying to avoid estrogen and progestin, we do have copper, just not something that we use often. Your sterilization methods, so if someone has an implant to block their tubes, they want to get tubal ligation or their tubes tied, and then you also have a vasectomy. And our hormonal methods that we have, the oral contraceptives, right? So looking at all of these different options. So when we talk about oral contraceptives, that's just the big umbrella, saying that the route in which they receive that medication is orally. But I have different combinations that I can give them, or not a combination at all and just give them a progestin-only pill. So that's what we call POPs. And then you have your combination of estrogen and progesterone. So you'll see those abbreviated as COCs, combined oral contraceptives. We also have the patches, the rings, the injectables, implants, and then we talked about the emergency contraceptives that we're going to look at as well. So when we're looking at this and we're talking about the effectiveness of the types of contraceptives that I'm going to give my patients, I can look at this chart and simply say, hey, the more a patient is involved in having to actively participate in preventing a pregnancy, the less my effectiveness is going to be, right? So in the top, the 99%, you see your LARCs, an IUD or an implant, because I don't have to actively do anything, right? Once I go to the doctor, you put that device in me, I'm okay. My vasectomy and my tubal methods, right, because we're physically trying to block that from happening. A shot is because they get that every so often. They're not taking something every single day. Your pills and your rings, you see the effectiveness starts to go down. Condom, diaphragm, cervical cap, because that's something that they have to do in that very moment. The effectiveness goes down because they're not using it, okay? So these are our basic contraceptive methods. This is where, actually going back, this is where I'm going to start asking you potentially questions for the exam. Everything else was just building up to this, okay, so that y'all are tracking. So looking at this, we have a male condom and female condoms. When you look at the male condom, essentially what it's trying to do is make sure that the sperm can't get to the egg, and it also helps decrease STDs. So even if you are giving a contraceptive, you need to make sure that if someone is worried about STDs, that they still know that they need to use a condom for that. Also making sure that they know that lambskin condoms do not prevent against STDs, okay? So if someone is allergic to latex and they're using lambskin, they are still at risk of potentially contracting an STD, and that's very important because some people don't know that. And then they shouldn't be using them, saving them, anything, buy new ones after you use them, okay? Because we just said that they're collecting sperm. Female y'all are making faces. People try to rinse them out and reuse them, okay? So just saying. Female condoms. These are not as common as the male condom. but they are still something that can be used. So what they're doing is they're essentially, it's plastic, they're inserting it into their vaginal area, again, preventing that sperm from entering the uterus where the egg may be hanging out. So we're trying to, again, prevent that pregnancy. You still do have that reduction in the STDs because it still falls under the category of your condom. And again, single use, so they should be disposed of. Diaphragm and your cervical cap. These are used for your females. They are not going to be something that they have to throw away after a single use. They can reuse these for a couple of years. They do need to, you do need to know that neither of these are going to protect the patient from an STD. This is specifically helping with pregnancy only, okay? So looking at this, just understanding that you need to leave it in place for 6 to 8 hours after they have sex because the sperm can still be, hanging out and swimming, okay? And then remove within 24 hours, so making sure that they're not leaving it in there for a very long period of time. Your diaphragm is going to get fitted as well as your cervical cap by a healthcare provider. So it's individualized to each person. So the female condom, the difference between this and a female condom, the female condom is just a general thing you can go and buy, right? It's not tailored to me. Versus when I look at a diaphragm or a cervical cap, that is tailored to me and my body. Your diaphragm, replacing it after 1 to 2 years, looking at your cervical cap, replace after 2 years. Make sure that you also let patients know that they can use a spermicide, or they should, bless you, use a spermicide as well with this to, again, make sure that we have two things essentially in place. So this is a physical barrier, but I also use my spermicidal cream, jelly, what have you, to make sure that I'm killing any of the sperm that would be there as well. So big things here are the things that you see in bold, and making sure that you understand that you're fitted by a healthcare provider. This is not an off-the-shelf type of thing. Your birth control or your sponge, and then your birth control or your sponge. Your birth control sponge or your spermicides. So your sponge is essentially there to, if the sperm get in contact with your sponge, then the spermicide that is inside of the sponge is supposed to kill the sperm. So of course, any of these need to be inserted before someone has sex because you do it after, defeating the purpose, okay? Remain in place 6 hours after, and they have up to 30 hours before they need to remove it. Looking at your spermicides, again, this is something that is over the counter. They go, you can get the jelly. They have it in so many different ways. Jelly, film, creams, lots of different formulations. So it depends on the preference of the two people who are using it. Oh, shoot. I'm sorry. So again, making sure that with this, you understand that they can use it alone or with one of these caps, the sponge, all of those things that we already talked about. When you look at spermicides with a condom, female or male condom, that is where you can have issues because it could potentially break the condom. Okay, so that is not required. And you see that we didn't say anything about spermicide when we were looking at the male or the female condoms. Okay, so that's more so with the things that we are inserting as physical barriers where you see the spermicide come into play. And you can also just use spermicide by itself if somebody wanted to. Looking at your tubal implant or your tubal ligation, your tubal implant, again, you see this device here where they're putting it in the tubes to block that egg from being released or potentially block the sperm from going in here, which it usually doesn't, right? It's getting pregnant here. But you also have your tubal ligation. This is more of a permanent, sometimes solution. People do go and try to have this reversed. But when you're looking at this, they're cutting off, tying, sealing, burning the tubes so that there's no pathway essentially for the sperm and the egg to even meet. So blocking the path from the ovaries to the uterus. Egg can't reach the uterus, sperm can't reach the egg, right? It's cut off that highway. It's like if we had a bridge and we remove the bridge. Now you can't cross the water. I mean, for the egg and the sperm. Vasectomy. So when we look at our vasectomy, what you're doing here is quick procedure. They go in. Your target here is your vas deferens. So they cut, close it off. There is still sperm that is being produced. It is just not leaving the testicles, okay? Could potentially be reversible. I have a friend who he's like, I have 5 kids. I don't need any more kids. And so he said, I'm going to get a vasectomy. He did the vasectomy, and his wife, he had a new wife, and she wanted to have a baby, and because she didn't have any kids. And he was like, okay, sure, I'll go reverse it. He's like, it's not going to work. I was like, okay. And she got pregnant, and he was like, I did not think that this was, what am I supposed to do with 6 kids? But I'm glad that it did work. I'm glad that it did work for him, because he ended up passing away. And so now she has, his widow has their child, and it was supposed to happen. So you can see where this does work. It is difficult, but it can work, okay? Looking at your estrogens and progestins, be familiar with everything that is an estrogen and be familiar with everything that is a progestin. When we look at some of the generations of our progestins, you're going to see that we have several different generations of the progestins, and we will talk about those when we get to our POPs. And then your estrogens, you see that we have ethinyl estradiol and estradiol valerate. Most of the time in our combined oral contraceptives, you're going to see your ethinyl estradiol. Your mestranol, I don't really see this used often at all. We do see the estradiol valerate, but again, it's only in one of the brands that is made. So this is like your number one. Over here, we see several of these. Depending on what we're trying to target with our patient, we'll use a different generation of our progestin to try to target certain things if we need to. Now, looking at your estrogens, when we think about these, they're similar to our estrogen hormones. We're mimicking that, and we're trying to make the body's cycle, which you will learn later, mimic with our estrogen replacements, okay? So our medication, our estrogens, are mimicking our body's natural estrogen hormones. You again see the same estrogens that we talked about, our estrogen hormones that we talked about, binding to those target cells. So there's several different places, which is why we are very cautious with the dose of estrogens that we use. So you see it can bind to the breast, the uterus, the brain, the bone, the liver, the heart, several other tissues in our body. Estrogens are in a lot of places. So when we get into this and we talk about the adverse effects of our estrogen, kind of keep in mind where it's binding to, because that plays a big role in the adverse effects that we're going to talk about. So your mechanism of action, essentially what it's doing is trying to say, hey, I want you to have that uterine lining grow during the first part of their cycle, their menstrual cycle. What will then happen naturally in the body when our body produces estrogen is that's how we see females essentially develop. So once they hit puberty, you see that their breasts will start to change, things like that. Definitely a big deal when we're talking about pregnancy and how people's skin changes sometimes whenever they're pregnant, just like we do whenever we're going through puberty. Looking at the regulation of our metabolic processes, look at all of the places that it binds to, right? So the bone growth, cholesterol levels, I'm binding all over the place, so this makes sense. I'm binding in the brain, I'm binding in the bones, I'm binding in the liver, so that metabolic metabolism and your metabolic process, it makes sense as well. And then suppressing your LH and FSH. We are going to talk a lot more about LH and FSH in a different lecture, but just understand that it's also regulating and suppressing that release from your pituitary gland, and we're going to go over that a lot in negative feedback a lot. Your progesterone, looking at this, just understanding that our progestins that we have in our contraceptives are, again, mimicking the progesterone that's naturally in our body. What they're doing, again, these are sex hormones, both of them that we're talking about still. So reproductive tract, breast, central nervous system, also binding to several other places. Your mechanism of action that you have looks very similar, but you see also, we see where it deals with the gonadotrophic hormone production. So it causes changes in the gonadotropin hormones. You also see, again, the metabolic processes being regulated and that suppression of LH, not the FSH that we have on this side, with our estrogens. So most of the time when we're using these, with our combined oral contraceptives, we use these together to get to suppress essentially sometimes or control, depending on what's going on with your patient, ovulation and all those things to make things more predictable. Also, if someone doesn't have a normal period or menses, we can also use these contraceptives to help balance that. People who have acne, we can use it. So there's several different indications that we're going to talk about. Your IUD, this is a picture of an IUD, so small T-shaped device. You're going to have it fitted and inserted by a healthcare provider. Also, it would need to be removed by them as well, okay? So our caps and the other stuff that we were talking about, right? It's just fitted by a healthcare provider, but that doesn't need to be removed. This will be removed also by a healthcare provider. Your copper IUD, we'll talk about this one a little bit more towards the end, but again, a different form of IUD, an older form of IUD that we used to use, but it does stay in the body for up to 10 years. So if someone knows that they don't want to become pregnant for a very long period of time, this is an option for us. It's just not a great one, and they're trying to come up with new ones. There's studies that they have about this right now, so we'll see where that goes. And then your hormonal IUD, these vary depending on which IUD you prescribe to the patient, but they stay in place for 3 to 8 years. So you still need to have that conversation with the patient to see, hey, if you're trying to get pregnant within the next year, there's no point in us doing an IUD because it's more invasive versus someone who is like, hey, I want to get pregnant in 4 or 5, 6 years. That's when we look at these long-term options for the patient. That's whenever we would like to do a LARC. So we can do the implant or we can do an IUD in that situation. Looking at some implantable hormone contraceptives, and I want to draw your attention to this because a vaginal ring being an implant can be easily removed, and it is placed by the patient, okay? You prescribe this to the patient. It looks like one of those old school plastic bracelets that you used to wear. It's not very thick. They bend it, they insert it vaginally themselves. They can take it out themselves. It's not something that's very long term. Whereas when you're looking at a birth control implant, that is something that is going to be more invasive. It's a small incision that they place on the patient's arm, and they insert the implant. And so you see it's a matchstick size rod. Does anybody even use matches anymore? Matches. So it's not big. And then sometimes people will have where they move. You do have some complications sometimes with them. The same thing with the IUD, right? Everything isn't perfect. So if you are doing an exam or something like that on a patient, just make sure that you're checking that everything is still where it's supposed to be, and asking them if they have experienced any discomfort, things like that. So when you're looking at your vaginal ring, you see that it has estrogen and progestins in it. They're going to put it in for 3 weeks. So again, we dispense this from the pharmacy. The patient takes it home. They insert it themselves. It's a standard size, so maybe a little bit bigger than like a silver dollar, if people remember those. And then after their 3 weeks, they remove the ring on that 4th week, and that's whenever they will have their cycle. Okay, so that's whenever they will actually start bleeding once they remove that ring. And then after that week goes by, they put in a new ring. Okay, so this is not something that they're keeping and using several times. There is a new vaginal ring that we have that just came out not too long ago, and they can use this. We'll talk about it at the end. They insert it themselves as well. They leave it in for 3 weeks. They take it out. On that 4th week, they have their cycle, but instead of throwing that one away, they can reuse the same ring for up to a year. So they rinse it out. They have a pouch that it comes with. They rinse it off, and they put it in that pouch, and they reuse it again once that 4th week is up. So a lot of contraception management is them making sure they know when they have a week off of their contraceptives. Because even with the oral contraceptive, any oral contraceptive, the same thing. Once they take 3 weeks, usually we can also have somebody where they take 84 days. But once they take 3 weeks of that medication, they're going to have a week off. So they need to remember when they're going to start up again. And that's the very important part of it. Okay. Your implant, you see, this one just has progestin only. And I already told you they're going to have a small incision. They will get a little bit local anesthesia, right? So it's staying in that area where we're going to cut. and then put in the implant, and they're good to go for up to 3 years. Again, sometimes if you do have a complication where it moves, things like that, you will see where you'll have to go back in and deal with it. But you can remove it anytime before that 3 years. Don't offer this unless someone wants a long-term solution for themselves. Your patch, this is a thin patch. There are several different areas that a patient can place it on their body. Again, it's going to go through that skin, so your skin is acting as a barrier for your patients. You see, you can put it on your abdomen, your butt, your outer arm, upper body. There's several different places. With this, you're applying a new patch every week. So again, you would prescribe it. We dispense it in the pharmacy. It doesn't require anything from you except for that prescription. So a new patch every week, and then after that 3rd week, they're off for a week. That is when their cycle will occur. This does have a very high level of estrogen in it. And because of that, that's why you don't see us use it anymore, because there were a lot of the adverse effects that we see from high levels of estrogen, like clots, heart attacks, strokes, things like that were happening. And so that's why we don't use these as much anymore. You will see some patients who still love it because they don't have to take something every day. They just have to remember that they need to change a patch every week. And that's easier for some people. The injectable birth control. So when you look at this, this is our depot shot. It is medroxyprogesterone. You're giving this injection in the arm or in the butt, wherever they have more fat is better. And you see that they're getting it once every 3 months. It is not the most comfortable thing. They're sore for a little while. So remember how I told you guys, anytime you do a depot shot, your patient is usually going to be sore for a little bit, because that medicine is going to be in their body for a month, 3 months, what have you, and trying to slowly get released. So we just tell people to kind of make sure that they're moving around still, so that they're not getting sore. Eating a diet rich in calcium and vitamin D, which is why we don't see this used as much anymore. What that is hinting to is some of the side effects that we're going to talk about, but the longer that someone is on these shots, the more likely they are to lose some of their BMD. So you do see that happening, and it does come on pretty quickly. So usually within that first 2 years. Some people stay on it and they're just fine, and they don't have dramatic bone loss, and they will take them for years and years and years and years. Another big thing with this is going to be weight gain, but I think you'll see that later, where some people, whenever they take this shot, they will gain a lot of weight. Okay, so this is just essentially telling you again, as a whole, how our contraceptives are working. So I'm trying to suppress ovulation. I'm changing that endometrium, and I'm making that implant of that egg, if it does join the sperm, I'm trying to make it a not fun place, right? I'm trying to make it inhabitable. So like when it's really hot in here and we have to come in here and learn, and you're like, oh, just get us out of here. We have the doors open, the fans on, and you're like, anything to get out of here. That's what's happening whenever we use contraceptives. Our endometrium lining is not a great place, so the egg and the sperm that have conjoined are not going to implant, and therefore you don't have a pregnancy that's happening. Reducing sperm transportation in the upper genital tract or your fallopian tubes. So again, making it an inhabitable place. It's just trying to make the sperm not enjoy where it is, okay? So if I make it the sperm transport decrease, or thickening the cervical mucus, now it's harder to move, right? So my swimming has now decreased my chances of surviving long enough to reach the egg, because I've been slowed down by thick cervical mucus. Now I'm decreasing the chances of pregnancy. Are these 100% when people are using contraceptives? No, they are not, unless they do something that's more permanent. And sometimes, again, depends on if somebody sneaks past the goalie, right? That's what happens sometimes. So just understand that the more adherent, especially to your oral contraceptives, that a patient is, the more likely you are going to have success when it comes to the contraceptives. Your orals are your biggest ones that you need to make sure it's clockwork, the same time every single day. All right, your combined oral contraceptives. So again, when we were looking at this is just giving you some information about how they are working together to deal with the different levels of estrogen and progesterone. You can read over this. This is more of an FYI, because the mechanisms that I talked to you about are the ones that I want you to focus on more. But what I've seen is that this slide kind of helps some people understand a little bit more how things are working whenever we go into the side effects and the different levels of progestins. Looking at our effects in our combined, we'll take a break in like 10 minutes, okay, whenever I get to a good stopping point, since we took a long time to start. So we already said what we were using them for, right? I'm trying to prevent implantation from happening, that fertilization even of the egg from happening. So that's two different ways that I'm working. Here are the other things that I told you that we also can use some of our contraceptives for, specifically our combined oral contraceptives. So always look at the top of the slide to see what you're talking about, because it switches as we go through this lecture and they're not all the same. So I can regulate someone's hormone if someone doesn't have a normal cycle. So let's say someone's like, oh, I have my cycle once every 3 or 4 months, right? That's not what should typically happen. And so you can try to manage their cycle for them with the combined oral contraceptives. We're going to talk about menopause, so you can see some of those perimenopausal symptoms being helped as well, because in my combined oral contraceptive, I have that estrogen. Some patients who have heavy cycles, again, or that irregular bleeding, I can decrease some of that bleeding with some of these that we're going to talk about. And then looking at your reduced risk of some of those cancers that we see, so endometrial, ovarian cancers, you can see that with some of our progestins that we add to our combined oral contraceptives, we also may be able to decrease some colon cancers in our patients. So big thing, preventing pregnancy for acne and specifically for acne. So some patients, especially when they're younger, they come in, they have acne. Again, this is all due to their hormones. You're going to learn more about that. But these contraceptives are specific to targeting that acne, and that's because of the different levels of progestin and estrogen that we have put in those pills to try to help that patient not have those breakouts as much. Your premenstrual dysphoric disorder, we have 2, I think they're coming out with a couple of more that help specifically with your premenstrual dysphoric disorder. And then those heavy periods, if we're trying to target those, you see that we have the Natassia, which we said had that estradiol valerate that wasn't used often, only in that one. But this one is the one that we said, hey, we've seen with studies that it does decrease the flow of periods for some of our patients. Looking at off-label uses and why we use it, there's several different things: excessive hair growth, so your hirsutism, PCOS, or your polycystic ovary syndrome, anemia. There's some of our contraceptives that we have that have iron added into it, so it's also a way to help them. And it also depends on why that patient has anemia. Are they having anemia because they're bleeding so much? Like, what's going on? So there are a lot of your off-label uses. I'm going to be asking you more so about your FDA-approved indications that we have, okay? So when you're choosing a contraceptive, there's so many different things that you have to take into consideration, a lot of things. And so big thing that I want you to know here is that simply that. There are so many things. You have to look at the patient. What do they prefer? Do they want to have an injection? Do they want to take something every day? Would they prefer a ring? Do they want to try what their friend tried to see if it works for them? Have they previously tried something before they came into you that they would like to keep using instead of you changing them to something else? Can they swallow pills? So there's just a lot of things that come into play. Just think about those. Not going to directly ask you something from here. Another big thing about this is also cost. Again, here with our monopoly money, right, we're not so much worried about that. But on the outside, newer contraceptives do cost a little bit more, and a good resource that you have could be for a patient who doesn't have insurance and things, or the health department. They will also cover a lot of things for patients and provide contraceptive services for them sometimes if they can't afford it. So it's not always an option of we have to make them pay out of pocket. Sometimes you have to explore and refer them somewhere else if they can't afford the contraceptive for themselves. Now, this is a super, 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 super important slide, okay? This is the eligibility that we have for someone to receive that hormonal contraceptive, specifically talking about your combined oral contraceptive or anything that has estrogen in it. Because of the estrogen components and some of the things that we're going to talk about with these adverse effects, that is why we are very cautious with who gets them. So when you're looking at this, there are different tables that you can use online. The CDC has a MEC table or a MEC chart. There's so many resources for you to use. But what you'll see is that these patients are high risk. They should only be able to use a contraceptive if we have no other options for them, okay? So if they're an active smoker and they're over the age of 35 or 35 or older, they should not be using a combined oral contraceptive. So if I am a heavy smoker and I'm old, because now 35 is considered older, right? And at higher risk for clots, strokes, all of those things. And when you're talking about pregnancy and when we're looking at contraceptives, this is where now we would consider someone to be at advanced maternal age, okay? Whenever they have a child at 35. So I know like typically we're talking like 60s or we'll look at 70s, but for pregnancy, they keep dropping this age, okay? I got a good shock on my second kid. My doctor was like, oh, you're AMA. And I was like, no, I'm not, because I thought he was saying against medical advice. And I was like, no, I'm not. And he's like, yes, you are. Happy birthday, advanced maternal age. You're over the age of 35. And I was like, oh, that's raggedy. Don't tell me that, okay? I am not advanced. So all of the things that are in purple, I want you to pay attention to. I know it's a lot, but these are very, very critical things because you can have some patients who are on a combined oral contraceptive that you didn't put them on that ends up presenting with some of these things, and you want to be careful whenever and monitor them closely and potentially change their contraceptive that they have. Looking at blood pressure, clot, stroke, again, because of the things that my estrogen can cause, I'm more worried about that. Now, blood pressure, if it is uncontrolled blood pressure, okay, that is where we're more worried. If it is controlled blood pressure, meaning they are taking medication to control their blood pressure, I can have hypertension and still take these meds because when you put me on antihypertensives, it's going to bring my blood pressure down and I'm going to be in a safe range anyway. It should if I'm taking my meds. Your migraines increases your stroke risk, obesity because of the increased risk of stroke, clots, things like that, because they're not moving around as much is why you see that on there. So all of this stuff, when you look at it, essentially goes back to the increased risk of clot, stroke, like all of the cardiovascular risk that we would typically talk about. Your diabetic patients, again, there's a lot of dysregulation for them. Cancer, because we could potentially, depending on the dose of estrogen that we have, cause more issues or cause that to come back up for your patient. And your postpartum and or breastfeeding, we're going to talk about this. There's an increased risk of bleeding in those patients. There's also immobility depending on how they deliver their child for a little bit. And then you also have breastfeeding. Our estrogens can decrease the milk production that we have. And so if someone wants to breastfeed their child, they may not be able to breastfeed their child because they won't produce enough milk. We don't want to do that if that is what that mother chooses to do. So we will go to one of our POPs. And in a lot of these situations, this is where you go to your progestin only, or you will look at one of our IUD that is specifically progestin-based and not estrogen-based. So we do have options. This is just telling you again, if they had one of those higher risk on the other side, these are my options that I have. So if I was, a diabetic for over 20 years, I have my uncontrolled hypertension, you can consider a POP. If I was a smoker and I told you I'm not quitting smoking, I don't care what you tell me, right? POPs or progestin IUD. You also have your non-hormonal methods, but the issue with these, right? More permanent when you're looking at your vasectomy or your tubal ligation. But when you're looking at the condoms, diaphragm, cervical caps, less predictability, right? Less reliability on my patient to actually use them to not become pregnant if that's what they're trying to do. So this, and giving them something, in either an IUD or a progestin-only pill to take every day around the same time, and hopefully they will take it around the same time every day, this is more reliable statistically than you using the contraceptives as far as like condoms. Your IUD, your vasectomy, tubal ligation, of course, these are better, but these are more permanent solutions that your patient would be having if they did choose to do that. Misconception about contraceptives. So when I did my residency, we made a program where pharmacists could prescribe contraceptives without having to come to you all and bog you down if that's all that they needed was a contraceptive. So we created a program where they go through a whole algorithm, kind of like that previous chart that we saw to say, does someone qualify to be able to take a contraceptive, and we can prescribe it for them. Misconception that a lot of even pharmacists had was that, oh, older women, there's no reason for them to take contraceptives because they're just using it to prevent a pregnancy. That's the main thing that we think about. But you can have some older women who have heavy bleeding because they haven't completely gone through menopause yet. You also have different people who could be dealing with acne. They could have PCOS. There's so many different things. So don't think that there is an age limit to contraceptives. I think whenever I pulled all of the data, we had like a 60-something-year-old who was still taking a combined oral contraceptive. Also, because it has that estrogen, while they're transitioning from perimenopause to menopause, you can see where they're still using their contraceptive to kind of help with some of those symptoms that they're going through. But we're going to talk a lot more about the meds that we have for menopause. And then if they have none of those issues, those high-risk issues that we were talking about before, then you can use estrogen. So your combined oral contraceptives would be a good option for you. But when you try to stay less than 50 micrograms, really we want to stay less than 20 if we can. But there are certain situations where you will be over the 20 micrograms. 50 is extremely high. So for the sophomores, a little bit fresher for y'all than the juniors, but when we were looking at a lot of our meds, right, and we were saying, hey, this is the effectiveness of my contraceptive is going to decrease. That's where you will see us use this 50 micrograms because we know that the effectiveness is going to go down because we use some drug that interacts with it. And so therefore, I am offsetting what I'm technically losing. So I'll end up around 30 or I'll end up around 25. You'll have your patient come in because we don't know what it's going to land on, right? You have your patient come in, ask them what side effects they're experiencing, if any. And if they don't, then you're fine. So this is not used, the 50 micrograms is not something that you see used very often because of that side effect profile that we talked about. When we come back, we will look at our breakthrough bleeding and spotting. So let's take 10 minutes, so 11:18. Everybody should have the Dickey tables that were passed out to them. This was a doctor who came up with the Dickey table, so it's named after him. Kind of coincidence. And so he has all of the different pill activity that we're going to go over, and I'll talk to you a little bit about it more, so just keep that handy. This one is yours. You can write on it. Did y'all have enough in the other classroom for everyone? Does that mean no? Okay. So I'm coming over there. When we look at the breakthrough bleeding, so talking about breakthrough bleeding, right, you have several different issues or reasons why someone could potentially have breakthrough bleeding. It depends on if that patient is, thank you, taking their contraceptive how they're supposed to. It could also be because there's not enough estrogen or progesterone that's in the combined oral contraceptive that you gave them. So if, y'all need it? Okay. So if for whatever reason a patient comes into you and they're like, hey, I'm having breakthrough bleeding, I'm not, and what breakthrough bleeding is, or spotting, let me go back a little bit, is saying, I am not supposed to be bleeding. I shouldn't see any bleeding, right? So it's not their week off, right? They didn't take their 3 weeks of that active pill and get into the week of placebo or no hormonal contraceptive. This is happening because they are either having missed pills. So some people, they're not great pill takers, right? It's not a habit for them to take something every single day. So if they're taking a contraceptive, maybe they took it on Monday, they forgot Tuesday, Wednesday, Thursday, now they're taking it again on Friday. Not only are you increasing the risk of becoming pregnant, but now, like we learned in block 1 of your sophomore semester, right? There's no levels, right? I'm not reaching steady state when you're giving me something and you're taking it away, and then you give it to me again and you take it away. So my efficacy then decreases with that, right? So the pill is only going to work as much as the person is taking it. Interactions with other medications, like we talked about, I can have another medication on board that is decreasing the level of estrogen that I'm thinking I'm supposed to have, and therefore I don't have enough of the estrogen, or I don't have enough of the progestin. So I might need to increase those levels. And then seeing when you need to switch. So every contraceptive, oral contraceptive, and when we're specifically looking at combined oral contraceptives, do not have the same amount of hormone in them. There are several that do, but they don't always have the same amount of hormone. So if it is for any reason besides missed pills, right? So missed pills is more so like you talking to the patient again, giving them some advice. Hey, set an alarm to make sure that you're taking your pill around the same time every day. Maybe have a pack at your desk at work and one at your house. Don't leave one in the car. We don't leave meds in the car because of the sun. Okay, but like tell them maybe put it in these two places so that you can remember where you're to take your med. And if you left it at home, you don't have to wait until later on to take that med if they're choosing to take it in the morning, because it doesn't matter if they take it in the morning or at night when we're talking about their contraceptives. But again, I can now, if it is for any reason outside of the missed pills, I can try to say, okay, or an infection. If they have an infection, clearly you need to treat the infection with what? What do we treat infections with? I can still see y'all over there. I see no mouths moving. Okay, I see you. So we would treat the infection, right, if it's a bacterial infection, with an antibiotic for that patient. If for whatever reason an adequate amount imbalance between estrogen and progesterone, I can switch their oral contraceptive to something else. Now, you can potentially see this when someone initially starts their contraceptive. It is common for you to see sometimes breakthrough bleeding, right? Because you're introducing these new hormones to their body that they haven't been taking. But after a while, it kind of goes away. We'll talk about that in a little bit as well. So this is just telling you, hey, there's several reasons why I can have spotting. And this is the main idea of this slide that I want you to carry, because I don't need you to remember all of these things. There are several reasons why I could have spotting, and I can potentially change the amount of estrogen or progesterone by changing their pill, okay? Looking at your patient instructions, this is going to be you, this is going to be the pharmacist, this is going to be the package insert that is attached to their contraceptive. I will bring one back when we do class at 1300. It's huge. All of the things that are going to be on that packet. The patient is likely not going to read all of it, or they're going to read all of it and be terrified to take their contraceptive. So what I like to do is open it for them and flip it to the part that shows them what to do whenever they miss a pill. Because a lot of patients are going to miss a pill. And depending on how many pills they take and which type of contraceptive, oral contraceptive we give them, it's going to be a different makeup schedule for that patient, okay? So this is just saying, hey, when should you expect for your cycle to come, which is based off of when they started. What is an active pill versus an inactive pill? So you keep hearing me saying that they're going to take active pills, or they're going to use that active hormone for 3 weeks, and then they take out that contraceptive, or they stop taking their pill for a week, and that's whenever they have their cycle. So it goes over all of those things. But if they have never used a contraceptive, that is also your job, right? Not to give them something to read, because people don't like to read. To them, that's what we're here for, right? So you can tell them and they can supplement with the reading, but that is what you are supposed to be there for. So that is what your patient package insert has on it. We're going to go over the different starts that you have. So a quick start, a Sunday start, or a day one start. Depending on when that patient chooses to start their contraceptive, they may or may not have to use a backup method, meaning a condom with staining from abstinence, then you need a condom. But with staining from sex, okay, so these are different backup requirements based off of when they choose to start the contraceptive. And then, again, remembering no barrier to STDs, STIs, okay? They have to use a condom and not a lambskin condom if they're trying to be protected from STDs. The contraceptive is just helping them prevent pregnancy or maintain what other condition we're trying to help them with. Now, this is very important because we need to know how to counsel that patient whenever we prescribe the contraceptive. So we have initiation days. You have the Sunday start, the quick start, and the first or the same day start. Your Sunday start is the most popular method that we have because this helps that woman not have bleeding on the weekend. Okay, so it avoids her withdrawal bleeding right here, avoids withdrawal bleeding on a weekend, and she can decide if that's a priority. So if I want to go out and party on Saturday, Friday, what have you, my menses or my period should technically, if I do a Sunday start, happen during the week to where by the weekend, I don't have to worry about it again. Okay, so that is, again, a priority for some people. So what you're doing here, your first tablet is taken on the first Sunday after their cycle has already started, so after the beginning of menstruation. So let's say I start my period on Friday, right? Then I wait until Sunday to start my new pill pack that you gave me, that you prescribed me. Okay, that is a Sunday start. If I started my cycle on Saturday, I have to wait until Sunday until I start my pack. Okay, so that is your Sunday start. Big benefit to this is that they shouldn't be bleeding the following weekend. Your quick start. So this is going to be any time that's post-menses. So let's say I walk into the clinic and I'm like, I want to start a contraceptive today. And it's Thursday. And so you're saying, okay, that's fine. And they go to the pharmacy, they pick it up, and they start taking their pill that day. That is your quick start. You're saying you're taking it that day. Any time that is post whenever they had their cycle. So I would have had to have my cycle already, not actively having my cycle, okay? So anytime post. I do need a backup method for 7 days. And that is also the same with your Sunday start. I do need a backup method for 7 days. And this is important because some people think, well, I already started my contraceptive, now I'm good, right? What's wrong with this? Have I reached steady state? Have I introduced this pill enough to my body to know that it's supposed to be following that mechanism of action of what my drug is trying to do or prevent the pregnancy if that's the indication? No, I just started taking it. It's not in my body yet. Okay, not at steady state, not where I should be. So backup method, backup method. Your first or your same day start, this is when my cycle has started. Okay, so today is, what day is it? Tuesday. Today is Tuesday. And I started my cycle today. And I went to the doctor today. And I said, I want to start my contraceptive now. Because I am already shedding my endometrial lining, right? I'm already bleeding and I just started today. I can take my contraceptive, and this is the one that says I do not need a backup method because I'm already shedding everything out, right? I wouldn't be shedding everything out if there was a viable pregnancy there, okay? So that's why we tell patients this doesn't abort a child if somebody is already pregnant. But this is preventing it from happening if someone wants to do that, okay? So Sunday start, I started my cycle and I get that first Sunday after, that is when I'm going to start it. My quick start is anytime after I have started my cycle that I decide that I want to start my contraceptive. Backup method for both of these, right? Because my cycle has already happened. First or same day start is saying, hey, I started my cycle today, and therefore I want to start that contraceptive today. I don't need a backup method because I've already started cleaning, right? I've already started bleeding. So that is how you remember there, I don't need a backup method. I'm not pregnant because I'm shedding my endometrial lining, okay? So 7-day backup for Sunday and quick first, or same day start. Do I need a backup? No, no backup. All right. This is the different formulations that we have for our combined oral contraceptives. So they're provided in several different ways. You have monophasic, biphasic, triphasic. I'm just going to tell you about this. I'm not going to test you on this because it is not that, I mean, it's important, but it's not that important. All I want you to know from this is that most of the time we're using monophasic. Monophasic is easier for your patient to remember. It's easier for them to catch up if they actually miss a dose. And it also doesn't have the fluctuations in the hormones like our our triphagic, quadriphagic. It's cleaner. So if you look at this, you'll see where all of these are blue. Okay, so this is what your contraceptive pack looks like. And you have all blue pills. So these are all of your active pills. Here, your patient will not be bleeding. This is their last pill. When they take this, these are all placebo pills or sugar pills. Okay? If it helps your patient with remembering to take a pill every day, you can tell them to take these placebo pills every day. I also tell them to at least go and punch them out so they know when they need to start a new pack. That's just how I recommend. But some people, once they've been on these for years, they get here, they throw their pack away, and they have an alarm set in their phone. They know when they're starting their next pack. But when they initially start, I'll either tell them to continue to take these or at the very least punch them out so that they know, oh, once I got here, I need to have a new pack and I'm starting back at day one. Okay? So that's why this one is usually the one that we prefer. It's a lot easier for them. When you start getting into biphasic, triphasic, these are essentially trying to mimic more what the body naturally does, and the levels of hormones will change. So in this biphasic one, you see that there's 3 colors. 2 of these are going to be more of the active pill that they have for that patient, but the levels of hormones are changing in here. Okay? So if I miss a pill, now it matters which week I missed a pill in, because I have different levels of hormones in each one of these weeks, depending on where they broke up their pack. This one is the triphasic, so every 7 days, level of hormone is changing, right? More confusing. What color am I supposed to be on? It does give them, there's a little triangle here that you can see, it does give them where they should start it. But again, if I'm a patient and I have never taken this before, this is overwhelming, right? This looks like my slides to the patient, okay? They're not gonna like this. So if I miss one here, but now I'm supposed to be here, how am I making up? And so in that package insert, it will tell them what they are supposed to do, okay? Quadriphasic, again, 4 times because of the quad. Extended cycle, continuous cycle. These are ones that you could potentially see. So when we're talking about extended cycle, this is them taking an active pill every day for 84 days, okay? You can do this with even a regular pack, those monophasic packs that we talked about. Just tell them, hey, instead of skipping that placebo week, they start a new pack. And you put that on your directions and you make sure that your day supply matches that, right? Because if you don't, whenever they try to get a refill at the pharmacy, I'm gonna be like, you still supposed to have some. You're like a month early, okay? So make sure that you annotate that in the day's supply matches, because if they're taking it 84 days in a row, that's a little bit different than them having a week off in between, right? So now my days don't match, all right? So when you're looking at this, 84 days of active pill, they have 7 days off, they will have their cycle, and then they start over again for another 3 months, okay? So this is a preference thing. There isn't anything that shows that this is harmful to the patients. It just depends on the patient. Clean me out every month, please, okay? Versus every 3, but it depends. Some people have very heavy cycles. Some people have very bad cramps. Some people like to travel without having to worry about their cycle and carrying all of the things, tampons, pads, whatever they use, right? So for some people, this is also convenience because they don't have to deal with having a menstrual cycle every month. Now I can deal with it every 3 months. And some people are very healthy and they want to have a cycle every month. Like, let me make sure and see that I am not pregnant, okay? That's how some people feel. And then you have the continuous cycle. These are monophasic pills that you can order. So you see here in this pack, it's these cards like kind of whip out, and there's 3 of them in here. And so this is all active. So instead of you ordering the 3 monophasic pills and telling them to packs and telling them to skip the placebo week, they would order just this, and it only has active in it anyway, okay? And so they just do each card every month, and then they have their week off, and then they do another one, okay? So what I want you to know from here, monophasic, we like it because it's consistent, it's constant, right? Helps avoid those mood fluctuations that a patient will have because the hormones are going all over the place. And then looking at your extended cycle, you can prescribe a monophasic and tell them to skip the placebo week, or you can get extended cycle, or your continuous cycle, it already will have those 84 active pills for you, okay? These are how some of your pill packs are made. Don't worry about that, FYI. All right, this is your missed doses. So this is telling the patient what they need to do. I'm going to summarize this because I like summaries, and this looks like a lot, and it's not that bad. Okay, so if they miss one, now this can change if they have a biphasic, triphasic, quadriphasic. This may not be the same exact thing. So I want you to just remember this, the basic principles of this, and then understand that there are variations. So if they miss one dose and it's been less than 48 hours, they just need to take it as soon as they remember. So let's say it's Wednesday and I look and I'm like, oh snap, I forgot Tuesday. So on Wednesday, I'm taking Wednesday and I'm taking Tuesday, okay? Because I remembered at that point. Let's say it was Tuesday and I normally take them in the morning, but I got home and I was like, oh yeah, I forgot to take that. I can take it Tuesday night. It's fine. As soon as they remember, because it's just one, okay? So less than 48 hours, one, take it immediately. If it's two or more consecutive doses and it's been over 2 days, over 48 hours, take it immediately, right? Take those 2 doses that they missed, but now they need a backup method because that drug has been out of their system for too long. We hit over that 2 days. Now I might be below my therapeutic level to perform my mechanism of action to prevent the pregnancy. So you need a backup method. If your doses were missed during the 2nd or the 3rd week, what happens is instead of them skipping that placebo week or trying to catch up on more than 2 tablets, they start a new pack, okay? So skip everything, start a new pack, they need a backup. So the only time that I don't need a backup is if I only missed one. If I missed one, I don't need a backup because it hasn't been longer than 48 hours. So no longer than 2 days and just one, I'm okay, I don't need a backup. More than 2 or more, okay, I need a backup because it was also over 2 days because it was greater than 24 or 48 hours, so greater than 2 days. And then if it's anything more than that, is how I remember it in my brain, right? Anything more than that, or if I was in that tail end of the week, start a new pack. Just throw it all away and start over, okay? Is what you would have to tell the patient. Now, for you, that means something because what you prescribe to them now is going to be off a little bit, right? Because they had to start over on that patch and they wasted a lot of those active pills. I will say this, if you're initially prescribing a contraceptive, just give them 3 months worth to see if they like the contraceptive that you have put them on, and then you can prescribe them for a year, and we will give them a year supply at one time of the contraceptive. That's one thing that we will provide to them all at once if you write it that way for us at the pharmacy, okay? That way they're not coming back into you for refills, and they're not coming back to the pharmacy every 3 months for refills, okay? So it helps both of us. This is telling you some of those health benefits that we already talked about, right? So if you have the endometrial or ovarian cancer, you can see the risk of these being decreased while someone is on a combined oral contraceptive, but you can see a potential increase in breast and cervical cancer depending on how far removed that patient is from it, because remember, we said that our estrogen can bind to all of these different locations. Decrease in ovarian cysts, benign breast disease, fibroids, ectopic pregnancies, the menstrual irregularities, heavy bleeding, all those things that we talked about. These are the benefits that we get from using that combined oral contraceptive. Whenever I'm looking at estrogens and breast cancer, all I want you to remember is that when you're looking at using potentially estrogen in breast cancer, this is a topic that they continue to go back and forth. They're currently saying that there is no correlation between estrogen increasing even the risk of breast cancer, although this could be contributed to the doses that we now use. But continue to keep an eye out on this. I'm not going to ask you this on the exam right now because technically and according to your MEC chart on the CDC, the answer is no, there is no correlation. That is the current answer, okay? So if somebody has a history of breast cancer, we should be saying, no, you can't use a combined oral contraceptive. We will give you an IUD, a copper IUD or something that just has progestin, even though we see that the data is all over the place with this. So that's why I'm going to stay away from this for an exam. Continue to look at research to see what it says. Your best bet when you're practicing is to go to the CDC website and look up the MEC chart, and it will tell you. So your CDC medical eligibility criteria, what you do is you go on there and they provide free, they have what's called like a MEC will. They will send that to your office for you even for free. But you can go in there and you see what the patient has and you turn the will and it will tell you, yes, they can use something or no, they can't use it, okay? Looking at estrogen and VTEs. The DVT risk does increase with a higher dose of estrogen, so that is why we try to stay less than that 50, right? So earlier we said less than 50. Ideally, we would like to be less than or at 20. So that's usually our starting point. Your big issue where you're like, I'm starting to worry is once you hit 30, okay? It's less than the risk that you would see the VTE risk with a 50 microgram dose, but these are not something that we like to be at, okay? So anything over 50, we definitely don't use. At 50, we have, okay? But that's when we're using that to kind of offset the interactions that we have with some of our meds, other medications that a patient could be using. Not the best option, bless you. So if you were asked this on an exam, less than 30 to 35 is acceptable. Ideally, we want to be at 20 and we start at 20. Okay? 50, only using that for patients who have interactions with other medications. You should not be using 50 in a typical patient with no interactions at all. That is a very high dose, and what you are doing is increasing their risk of a venous thromboembolism or your VTE. All right, cardiovascular complications. This is the portion that when we were looking at the high risk on the slide and why we're so worried about our contraceptives, our combined oral contraceptives, is that estrogen portion. So we have cardiovascular events that could occur. So if anybody has history, MI, thromboembolism, we'll talk about some of these, I think it's the next block or the third block. But this is where you're likely to see more of those cardiovascular complications. So on the high risk slide, it said the person was greater than or equal to 35 and was a smoker, or if you have somebody who smokes a lot of packs of cigarettes a day, this is where we're more concerned. Relative contraindication. So absolute contraindication means absolutely under no circumstances should we be doing it. A relative contraindication is saying it is a potential for me to give it to them. So for a patient who is less than 35 and they are a heavy smoker, meaning they smoke over 15 cigarettes a day, it is a possibility for us to give that to them, but you should definitely also be focusing on smoking cessation, okay? Because how do you smoke at 15 cigarettes a day? What do you? I'm just kidding. So when you look at this though, again, that risk is a very serious risk for somebody to have a cardiovascular event. So you want to decrease, right, those cigarettes and that nicotine if you can for your patient. Using your lowest dose, we already talked about. We start at 20. Staying below 30 to 35 is ideally what we would try to do. And then in these patients, especially if they are smokers, if they have those cardiovascular risks or any of those high risk behaviors that we said, and you're going to focus on just the purple, we will go ahead and look at giving them a pop. You do see a black box warning for the cardiovascular risk on our combined oral contraceptives that say, hey, any smoking, especially if you're over the age of 35, you are likely to see an increased risk of cardiovascular events happening to you and serious cardiovascular events. So remember that black box warning, cigarette smoking and serious cardiovascular events, okay? This is our Dickey table that I wanted to talk to you about. So this is reflective of, it changes, of course, every year. This has a lot of the things that were on our formulary, so within the DOD, but as we continue to change it, this kind of changes a little bit too. And it's kind of simplified. I will give you this paper on the test. I do not need you to remember any of these numbers. I need you to remember how to use the chart, okay? So you're not remembering numbers. You're not trying to remember all of these names. You're not trying to remember where they fall. You will have this paper, okay? When you look at this, a lot of times you will see different generic, these are brand names. These change, right? That's why we use generic names. But for the test, I will have the generic name. I'm not expecting for you to remember all of that. I will have the generic name. You will see these brand names. But again, I'm not testing you on this. I'm testing you on, can you use this chart to get the right contraceptive for the patient, okay? So are y'all tracking in the other room? You're not remembering numbers. I'm giving you this paper for the exam, and you're going to learn how, what we're going to talk about right now is how to choose the right thing for your patient. Okay? Yes, okay. So when we look at our sensitivities that we have, estrogen sensitivity, these are your patients who are going to present and they're going to have these symptoms, okay? So if I have a history of migraines, if I have a history of heavy cramping, if I ended up with preeclampsia while I was pregnant or hypertension while I was pregnant, if I was very if I had hyperemesis while I was pregnant, right? So excessive nausea and vomiting, weight gain because I'm retaining fluid at certain times, usually sometimes around when their cycle happens. This is an indication that the patient is estrogen sensitive. Now, normally I don't make you guys remember symptoms. You have to remember these symptoms because I'm not going to tell you what type of sensitivity the patient has. So you're going to have to look at the symptoms and say, oh, this is estrogen, or this is androgen sensitivity, or this is progesterone sensitivity. That will be you doing that, okay? So understanding how your patient will present will allow you to classify, right, what type of sensitivity they have, and then you will pick a pill that has low estrogenic activity in this situation because they are sensitive to estrogen. If I'm sensitive to estrogen, we want to avoid estrogen, right? Decrease those doses. So if you grab your Dickey table and you look, so you have a front side and you have a back side that has number 2 on the back side. So starting at the front side, where do we ideally want to start for most of our patients? What's the safe amount of estrogen that I should be using? 20. I want to start at 20. So I can look here and see all of my things that are in my 20 micrograms of estrogen. Now I see across the top endometrial activity, estrogenic activity, progestational activity, and androgenic activity. So now within my 20 microgram area, I can look anywhere. So this is what I do when I'm using this. I start at my 20 microgram area and then I look and I'm like, okay, which one is the lowest in my 20 microgram area for estrogenic activity, right? So what do I have there that's low? Low estrogen, right? But I can also do something as well. I can also just look in this estrogenic activity in this column and go down and find one that has the least amount for that patient who has estrogenic activity, okay? So on the exam, you are going to have 5 options. So you look up those 5 options and whichever one has the lowest amount of estrogen is the correct answer, okay? Now, listen to me well. Turn to the back and look at your progestin-only pills. Your progestin-only pills, do they have estrogen? No. But do we prefer a progestin-only pill over a combined oral contraceptive? No is the answer. We don't love to use my pops, okay? I do love my dad. I don't love to use pops. I don't like to use him. There you go. I don't like to use pops, okay? Pops are not as reliable and as effective in avoiding me getting pregnant, avoiding conception, okay? So don't pick a pop if you see that because it has no estrogen, right? But I'm not asking you for a pop. I'm asking you for a combined oral contraceptive that is effective in preventing pregnancy. So you pick one that has a low amount of estrogen, not where it says NA, okay? We had a warning. All right. This is just telling you different ways to manage. I'm going to end on this slide, and then we'll talk about the others later on today. So your estrogen excess, right? Again, I told you how your patient will present. And then, again, what you're trying to do is say decrease the amount of estrogen. Pay attention to the bold on these. And then you see here that you're going to use your NSAIDs if somebody is having issues with heavy bleeding, painful bleeding. We can use our NSAIDs for those, and we'll talk about, remember, NSAIDs next block. Estrogen deficiency, right? Not enough. So you'll see them having vasomotor symptoms. What those are, like hot flashes. They kind of present like they're going through menopause, but it's because they don't have enough estrogen. And that's what's happening in menopause as well, right? I'm decreasing the amount of estrogen that I have. So here, they're going to present the same way. Nervousness. They will bleed sometimes early on in their cycle, and pay attention to this because we're going to see where there's late bleeding, and you're going to have to correct for that. So in this situation, if I have too little estrogen, what do I do with my doses of estrogen now? I increase it because it's not enough to manage it. So this is what we talked about in the very beginning of the slides, right? When we said, hey, if I don't have enough and they're having breakthrough bleeding, I may need to increase the amount of estrogen or progestin, depending on when that bleeding happens. So this one is happening in the early point of their cycle, right, of their pill pack. It's happening within the first 2 weeks. And when we look at later, you're going to see where it's happening towards the end, and we'll deal with that one when we get there, okay? So deficiency, I'm increasing estrogen, okay? And then when I'm looking at excess, I decrease estrogen, all right? So I would look at this, go to my estrogenic activity column, pick the one that has the lowest or the highest amount to change their contraceptive if I needed to. Absence or withdrawal bleeding, of course, this should be excluding pregnancy, right? Making sure that they're not pregnant. Because maybe I got pregnant while I was taking my contraceptive, and that's why I'm not bleeding anymore. Okay, that's why I don't have a cycle, because now I'm actually pregnant. So there's no need for me to take my contraceptive anymore because I'm not preventing that from happening. Okay, it's there. Here you can see where I can increase the amount of estrogen if they do actually want to have a cycle every month, or they can say, actually, I like it. You told me I'm not pregnant, I'm fine. I like this, right? I'm not bleeding, great. Leave it like that, okay? So you could also potentially do nothing for that patient. When we come back at 13, we will start with our progestin sensitivity, okay? So big thing I want you guys to remember for this is on these sensitivities, you are going to see them, and you need to remember if they have a history of or a presentation of these things, what you are doing, which will be in the bold. You don't necessarily have to remember the examples that I'm giving you because you are going to have your Dickey tables, okay? All right, I'll see you after lunch.